Hi, welcome friends, welcome to our next case. So in this case, again, this is an acute abdominal emergency that has presented. So what are we finding? That this patient is a known chronic alcoholic. He also gives a very adequate history of hypertension, type 2 diabetes mellitus, which leads us to think that there are a lot of comorbids in this patient, right? There's a lot of comorbidities. And this patient has come to us with fever, with an abdominal pain, a right upper quadrant pain. Murphy sign is positive. Leukocyte count is high, it's around 18,000, which suggests that there is some active infection that is building up. We do a CT scan, and on CT, what do we find? We find this characteristic appearance of air present in the wall of the gallbladder. Now, where is this air coming from? In a setting of this patient who is coming with a lot of comorbids, is having some immunocompromised states like diabetes, like hypertension, diabetes more predominantly and profoundly being the greater cause, in fact, we would find the growth of certain organisms like Clostridium perfringens, Clostridium welchi, and at times some aerobes also like E. coli. All of these are going to grow inside the biliary tree or the biliary tract, and they are going to lead to a feature that causes gas gangrene or gas bloats in the walls of the gallbladder. This is what we commonly know as emphysematous gallbladder. Why emphysema? Because when we know the disease called emphysema, which involves air trapping or large air-filled spaces called bulla present in the lung, through which air cannot escape. So these on X-ray or CT appear as hyperlucent fields or hyperlucent zones. That is why this term has been given as emphysematous gallbladder, and it is mainly due to these infections by the bacteria that I previously talked of. Now, this is a very life-threatening condition. It can lead to gangrene, it can lead to perforation of the gallbladder. What to do in these patients? So, along with managing this patient for sepsis, giving adequate fluids and antibiotics, the definitive management of choice always is going to be an emergency cholecystectomy. Without doing the emergency cholecystectomy, we will always have a higher predisposition of a gangrene, a perforation, any of this which might lead to sepsis and MODS, that is multi-organ dysfunction syndrome. A combination of all of these factors have a very, very high mortality rate. So that is the case for us, emphysematous cholecystectis. Thank you. Happy learning.